Hey everybody, this is going to be a presentation on pediatric mandibular hypoplasia syndromes and its anesthesia considerations. It's going to be presented by Zachary O'Connor and myself, Tyler Corder, for the College of Nursing at the University of South Florida. Just to start off with the objectives for the presentation, we'll start off with a background about mandibular hypoplasic syndromes, go into the etiology, pathophysiology, show some patient presentations, treatment options, and of course anesthesia considerations, as well as a case study presentation to kind of bring the key points together. Getting into the background, you can see that mandibular hypoplasia is actually a pretty extensive group of craniofacial disorders of the mandible. It's often associated with various airway, feeding, as well as cosmetic abnormalities. Some of the big ones are Pierre-Robin syndrome. This can also be a sequence. Pierre-Robin sequence is really just isolated to jaw abnormalities and upper airway issues. And if it's Pierre-Robin syndrome, it actually involves other organs. And Pierre-Robin syndrome is really a triad of an underdeveloped jaw, a backward displaced tongue, as well as upper airway obstruction. And this one is often associated with cleft palate as well. Another one is oculo-auriculovertebral spectrum. Of this, you can include hemifacial microsomia, which is one side of the jaw is actually underdeveloped and one side is normal. Another one is Treacher-Collins. It's underdeveloped zygomatic arches. This one can also include eye socket abnormalities that has a downward slant of the lower eyelids. Can also include external and internal ear malformation, and this, of course, can lead to hearing loss early on. Another one is TMJ ankylosis, which is often a result from either trauma. Rheumatoid arthritis can cause this, as well as infection. And this is a fusion of the TMJ joint at the mandibular fossa. Another thing to bring up is some of these disorders can actually affect the maxilla as well. And the problem may not actually be an issue with the jaw size. It may actually be an issue with the angle of the jaw that's causing the mandibular hypoplasia. Etiology of mandibular hypoplasia syndrome stems from three categories. It can either be congenital, which is a poorly developed first or second branchial arch of the jaw. This can either be unilateral or bilateral. Developmental comes from an underdevelopment of the mandible that occurs for unknown reasons, and acquired comes from either cancer, trauma, infection, as well as radiation. The acquired etiology really can stem from a postnatal injury of the temporal mandibular joint. It's important to note that mandible formation often occurs early into the fourth week of gestation. Normally, neural crest cells move towards the head and neck region to begin development, and mandibular hypoplasia is believed to be a result of inadequate neural cell migration during this time. Pathophysiology really has a common theme of a underdeveloped or a poorly angled jaw. Patients may need correction early on in life due to an airway obstruction, and a tracheostomy may be necessary for a definitive airway. With the base of the tongue being commonly shifted posterior, these patients can be really prone to obstructive sleep apnea. With some of the syndromes, learning difficulty or mental retardation may be present, and feeding may be difficult. Some of these patients may present with a failure to thrive state due to poor nutrition, and some of these patients may show with a weight that may be significantly less than what you would expect for their age. Patient presentation most often includes a micrognathia, which is a undersized mandible, and this results in a overbite appearance. You can also have retrognathia, which is a posterior displacement of the mandible with respect to the maxilla. Obstruction of the hypopharynx is probably the most common issue with mandibular hypoplasia syndromes, and this is due to a posterior displacement of the mandible. This causes a poor position of the tongue, usually shifted posteriorly. You can also have a frequent hypoxic episodes due to airway obstruction since the tongue is shifted posteriorly. As mentioned earlier, these patients are very prone to obstructive sleep apnea. You can also have a failure of the palatal shelf fusion, and cleft palate results from this, and Pierre-Robin syndrome is probably the most common of the mandibular hypoplasia syndromes that's associated with cleft palate formation. These patients can also show with what appears to be a failure to thrive, and this is due to an inability to get any kind of adequate nutrition in. Sometimes these patients, when they're born, due to that posterior presentation of the mandible, they're simply just unable to latch onto the breast and get any kind of nutrition early on in life. They can also show with poor dentition, as well as since the tongue is shifted posteriorly, they can be very prone to altered speech articulation. Treatment for mandibular hypoplasia syndrome is either going to be a conservative approach or an invasive approach. With the conservative approach, it's going to be non-surgical, and this is usually done if the patient is expected to eventually develop their mandible, or if the mandibular hypoplasia syndrome is not very severe. With this, it's usually done with a BiPAP or CPAP, and this is implemented so that way the patient can have adequate oxygen exchange. Again, these patients can be very prone to obstructive sleep apnea. You may expect a gastrostomy tube to be placed, and this is done so that way the patient can have adequate nutrition, and it's usually accomplished with tube feeding. This invasive approach is, of course, going to be surgical. With that, you may expect a tracheostomy to be placed. This might be done immediately after birth. It really just depends on how severe the airway obstruction is. You might need to do a craniofacial dental corrective surgery. With this, a mandibular advancement can be done, also known as a mandibular distraction osteogenesis. A low-intensity pulsed ultrasound has also been implemented for these patients. With that, it's done for 20 minutes at a time with low-intensity ultrasound that stimulates healing and growth. And it's done every 4 days, about 5 sessions. And it's been shown to decrease pain in the postoperative period, as well as over the course of the early stages of healing, it's been able to enhance healing. It's also used as a guide to see how well the mandible is shaping, as well as just general healing immediately in the postoperative period. You can also do a mandibular advancement device, as well as a orthodontic plate with a velar extension. And again, all these treatments are going to be tailor-made to the patient. It really, again, just depends on what's expected with a patient. The main treatment goal is to help with the airway obstruction, but also done so that way it has a aesthetically pleasing look to the jaw. Another goal is to help with speech, as well as with the poor nutrition. The goal with that is for adequate nutrition without the need for a G-tube to be placed. Getting into some anesthesia considerations, the most common issue is going to be airway management with these patients. I'm sure you noticed a common theme of airway obstruction by now. Many practitioners will opt for a inhalation induction with maintaining the patient's spontaneous respirations, but you can very well use a intubating LMA to help use as a bridge to being able to intubate these patients. It's also rather prudent to have a fiber optic or a video laryngoscope ready, as well as a bougie. General difficult airway equipment is usually needed at the bedside. You can also do a nasotracheal intubation, and this helps increase the surgical view. It's really just based on surgeon preference as well. Some pharmacology that's important to note is that non-opiate analgesics are preferred, and this helps reduce the occurrence of respiratory depression. When you go to extubate these patients, unfortunately there's an increased risk for post-surgical edema, and because of this edema, you might need to keep the patient intubated going into the post-op period until the edema is able to subside.
Okay. For this case study presentation, we'll be looking at the anesthetic management of a patient with micrognathia, also known as mandibular hypoplasia. As we noted earlier, Stickler syndrome is amongst the numerous congenital diseases associated with craniofacial abnormalities. So getting into it, the patient is 12 months old with an unspecified gender. The original diagnosis for this patient was Pierre-Robin syndrome. However, the diagnosis was subsequently changed to Stickler syndrome due to the development of other musculoskeletal malformations, such as enlarged extremities. The patient was noted to have mandibular retromicrognathia and a U-shaped palate. The procedure to be performed was a surgical reconstruction of the U-shaped palate. On the right here, we have the profile view of the patient. We can see the severe posterior displacement of the mandible in comparison to the maxilla. So, at 12 months of age, the initial surgery to fix the U-shaped palate was attempted. During intubation, neither the vocal cords nor epiglottis could be visualized. Due to the complete lack of visualization, a Cormack and Lehane's grade of 4 was given. After 30 minutes of unsuccessful intubation attempts, the patient was noted to have gingival and palatal bleeding. The patient developed hypoxemia and the procedure was abandoned. Corticosteroids were administered to prevent subsequent airway edema, and nebulized oxygen was administered for 2 hours postoperatively. The surgical procedure was then postponed for 12 months. After 12 months, upon physical examination, the patient presented with enlarged extremities, hearing impairment, and was mute. At this point, the diagnosis of Pierre-Robin syndrome was switched to Stickler syndrome. The original mandibular retromicrognathia that was prominent at 12 months of age had assumed normal growth over the previous 12 months and was near almost normal size. So, after 12 months, the second surgical attempt was made, again to fix the U-shaped palate. The patient was connected to monitors and pre-medicated with 0.25 milligrams of IM atropine. Inhalation induction was initiated with a 50-50 nitrous oxide and oxygen mixture with progressive introduction of sevoflurane up to 8%. Following successful inhalation induction, an IV was placed and a 5% dextrose infusion was initiated. 20 milligrams of acetylcholine was administered to aid in laryngoscopy. During direct laryngoscopy, the epiglottis was easily visualized, however, the vocal cords were not. Again, a Cormack and Lehane's grade of 4 was given. Despite the grade 4 view, endotracheal intubation was attempted via blonde insertion in conjunction with external manual displacement of the larynx in a posterior manner. The intubation was successful and maintenance anesthesia began. The 50-50 nitrous oxide and oxygen mixture in conjunction with 2% sevoflurane was used to provide the maintenance anesthetic. Atracurium was administered as needed as well, and near the end of the procedure, spontaneous breathing was achieved. The soft palate and uvula were successfully repaired, and the patient was discharged on the 5th day post-op free of complications. 1 year later, the patient underwent another follow-up procedure to remove residual cleft in the hard palate that had not been repaired during the previous procedure. The anesthetic plan utilized mirrored the previous plan in that a 50-50 nitrous oxide and oxygen mixture was used in conjunction with 8% sevoflurane. Upon direct laryngoscopy, a Cormack and Lehane's grade view of 3 was observed. Endotracheal intubation was successful, utilizing cricoid pressure, and the patient was discharged on the 3rd day post-op following an unremarkable recovery. Okay, so moving on to a quick case study discussion and summary. Stickler syndrome is one of the many congenital craniofacial diseases. It has multi-organ system involvement leading to ophthalmic and musculoskeletal issues. Retromicrognathia results in difficulty with intubation, especially when using direct laryngoscopy. Video or digital assisted laryngoscopy should be used for patients with mandibular hypoplasia. Fiber optic intubation is considered the gold standard, however it was unavailable at the time of this case study. Inhalation induction with sevoflurane was chosen due to the smooth and rapid nature of induction, as well as the quicker recovery it allows if a patent airway cannot be established. Lastly, laryngeal mask airways have been recommended for airway maintenance in children with retrognathia in which endotracheal intubation cannot be achieved. Okay, and this concludes our presentation on mandibular hypoplasia and associated syndromes. If you have any questions, please post them in the discussion board.